Okay, well, I think we'll make a start. There'll be other people come in as we go along, but welcome everyone to pediatric teaching today. There's a few more people coming in as we speak, but welcome everyone. I wanted to talk today about congenital heart disease, and I think this is very common, isn't it? Many children come along with different forms of respiratory distress or other manifestations of congenital heart disease. And I thought it would be good to talk about the common presentations of congenital heart disease and how we can make a diagnosis based on the clinical picture, which includes the age of the child and the way they present, the presenting problems, the clinical features, and the ECG and the chest X-ray. If you put all that together, especially knowing the different patterns of the presentation of forms of congenital heart disease, we can really understand. We can usually make the diagnosis without, even without fancy tests. So that's what I wanted to talk about today. So I thought it's worth, first of all, thinking about heart failure in terms of the clinical signs, and there are some general signs of heart failure. So tachycardia and tachypnea, they're general signs of heart failure, regardless of what type of heart failure you've got. There's tachycardia and tachypnea almost always. Then there are signs of congestive heart failure, right? And then after the general signs, there's a couple of types of heart failure. One is congestive heart failure, and the other one is low output heart failure. And when we see children with heart failure, we should ask ourselves whether or not the child's got predominantly congestive heart failure or whether they've got low output heart failure, because the causes are a bit different, and the severity is also a bit different. So the signs of congestive heart failure could either be related to right heart failure, that is, the right ventricle is congested and therefore there's a backflow of blood into the right atrium and the superior and inferior vena cava and all the systemic veins. And so in that circumstance, when you've got right heart failure, then the children have hepatomegaly because they've got a congested liver. They've got lower limb edema because they've got distended systemic veins and leakage of fluid into the extravascular space. And they've got distended or raised jugular veins. All right, and so that's right heart failure. When you see heart failure, think, is it congestive or low output? Is it right or left, right? And so right heart failure gives you hepatomegaly and edema and raised jugular venous pressure. And left heart failure gives you tachypnea and grunting and fine crackles throughout, and then signs of effusion. Most children who have severe left heart failure will have wet lungs, and sometimes that wet lungs will be just pulmonary edema, and sometimes it'll be pleural effusions. So when you see children with congestive heart failure, think, is it predominantly right heart failure, or is it left heart failure, or is it biventricular failure? And then there are some children that present predominantly with not so much congestive heart failure, but with low output heart failure. And that is that they present with hypotension. The signs that their ventricle is not just failing and congested and there's backflow of blood in the systemic veins, but there's not enough blood going around the body. So they'll have hypotension or weak pulses or a very narrow pulse pressure. You might measure their blood pressure and it'll be 70 on 50 with a very narrow pulse pressure. And so they have low output heart failure. They'll have cold peripheries and they'll have skin mottling. They'll really be in shock. They'll be in cardiogenic shock. All right. And so when we see children with heart failure, we get used to thinking tachycardia, tachypnea, and hepatomegaly being the signs of heart failure. But I want you to start thinking about, is the congestive heart failure, and if so, is it predominantly right heart failure or left heart failure, or is the low output heart failure as well, which with signs of shock? When we think about the causes of heart failure, I'm going to talk predominantly today about acyanotic heart failure. So not cyanotic heart disease, but acyanotic heart disease, where there's largely a problem with the left ventricle, so left to right shunts particularly. But when we think about heart failure, I think it's useful to consider all the different structures of the heart. So there could be a hole in the heart somewhere, and that could be acyanotic or cyanotic heart failure, depending on where the hole is and what other characteristics there are of the heart structure. So structural congenital heart disease is one of the most common causes of heart failure. But also think, could it be a problem with the valves, such as rheumatic heart disease, or even congenital valvular heart disease? Right? Could it be a problem with the heart muscle, like myocarditis or cardiomyopathy? There are some forms of heart failure, some viruses that cause myocarditis, for example, some forms of congenital cardiomyopathy. They're all illnesses of the heart muscle. Right? So if you think about all the different components of the heart, each one of them can have an abnormality. It could be structural congenital heart disease. It could be a valvular problem. It could be a muscle problem. It could be a problem with just the conduction system. So, for example, there are some children that have incessant tachyarrhythmias, like supraventricular tachyarrhythmia, and they'll go into heart failure. There's nothing wrong with the muscle of their heart or their valves, but they've got a cardiac conduction abnormality that puts them in heart failure. So it's important to think about that as well. And then some children will have pericardial disease. So they may have a pericardial effusion or tamponade or constrictive pericarditis, for example, with tuberculosis. And some children will have heart failure secondary to lung disease, like they've got severe pneumonia and they have heart failure because of that. And that's or they've got severe chronic lung disease and they'll have pulmonary hypertension and heart failure. That's also pretty common. And then occasionally you'll see children with high output heart failure from severe anemia. So the point of that is to have a framework for thinking about the causes of heart failure. So the next time you see a child in heart failure, you need to think, have they got signs of congestive heart failure? If so, is it right heart failure or left heart failure? Have they got signs of low output heart failure? And of the types of heart failure, the causes of heart failure, what are the possible causes? Is it a problem because they've got congenital heart disease, or a problem with their valves, or a problem with the muscle, problem with the cardiac conduction pathways? Is it a problem with their pericardium or their lungs, causing secondary heart failure? So it's just a framework for thinking about children with heart failure. So I'm going to talk today predominantly about acyanotic congenital heart disease, because that means children who are not generally cyanotic, so they're not generally cyanosed. And the reason to focus on that group is that they're about 3/4 of all the types of congenital heart disease. No, I'm going to try to talk about the different presentations of the commonest causes of acyanotic heart disease. So I think it's useful to start with a case, and this is a typical presentation. A 4-month-old boy presents with poor weight gain and recurrent wheezes and sweating and fast breathing whenever he feeds. So he's a breastfed baby. When he feeds, he becomes very sweaty and he pulls off the breast and he gets quite tired. This is his chest X-ray. His pulses are somewhat hard to feel, and on auscultation of his chest, you can hear wheezes and crackles throughout his chest, and his liver is enlarged. What do you think is the differential diagnosis of this? What would you be thinking about?
Some congenital heart disease and he's in heart failure.
That's right. He's got some sort of congenital heart disease. So Annette, of the types of congenital heart diseases, what do you think is possible? What's on your differential diagnosis here?
Ventricular septal defect.
Yes. And why do you say that? What makes you say that?
Well, those are the most commonest acyanotic heart diseases. So you have VSDs and PDAs and ASDs that are quite common.
That's right. And it's the age of presentation that gives you the clue in a way. Most VSDs present somewhere between 3 and 6 months of age. And so it wouldn't be surprising if this was a ventricular septal defect. Now, we see this type of presentation commonly, don't we? A 4-month-old boy presents with poor weight gain, recurrent respiratory distress, probably called pneumonia on various occasions, or recurrent bronchiolitis, but it might not be bronchiolitis. And so I think the differential diagnosis is bronchiolitis or a ventricular septal defect, or, as you said, and it may be a large PDA. And when we're trying to make that distinction between bronchiolitis and a form of congenital heart disease, then you can look at the different clinical signs to make that distinction. So babies with bronchiolitis, of course, they have wheeze and crackles like this baby, and they will often have a large liver, but they won't have any murmur generally, although sometimes it's hard to tell whether they've got a murmur because you're just hearing lots of crackles and wheezes throughout their chest. They won't have cardiomegaly, and they'll have a normal ECG. So in a way, you need to put all the signs together and work out whether or not this child is likely to have just bronchiolitis or whether the baby is likely to have a VSD. Whereas children who've got a VSD will have wheezes and crackles, just like this child. The crackles will often be a bit finer than the baby with bronchiolitis. They will have hepatomegaly. So in some ways they look very similar, but they will have a loud pansystolic murmur at the left sternal edge, and they will have cardiomegaly, the child with the VSD. And on ECG, they will have some abnormalities. So if you've got a normal heart size on chest X-ray and no ECG changes, then it's more likely to be bronchiolitis. But if you've got abnormalities on the chest X-ray and ECG changes, it's likely to be a VSD. What do you see when you have a look at this X-ray? What do you think? Is it the typical X-ray of a baby who's got bronchiolitis?
With bronchiolitis, you'd have a bit of hyperinflation.
That's right. Typically, with this on this chest X-ray, there is some hyperinflation, but what you see is that there's a congestion as well. Now, usually when you've got bronchiolitis, there's hyperinflation and the lungs look translucent, don't they? They look blacker than normal. But in this case, there is some hyperinflation, but predominantly there's congestion. All right, and you can see all of these white dots all throughout. These are congested pulmonary veins all throughout the lung fields, right? Where there's just increased pulmonary blood flow. Whereas when you've got bronchiolitis, you have hyperinflation and translucent or blacker lung fields, right? And in this case, the heart is large, right? The heart's large, the lung fields look congested, and there is some hyperinflation. Why do you get wheeze and hyperinflation when you've got a VSD? This is a very common problem with VSDs, is that they do cause wheeze as well. What's the reason? Well, wheeze is caused by bronchial obstruction, isn't it? Some sort of bronchial narrowing, whether it's with bronchiolitis or with asthma, you get bronchial narrowing. When you've got a VSD, because you've got the baby's got so much pulmonary congestion, the mucosa is also thickened because of edema. The mucosa of their bronchi is thickened, and so the airways are narrower. So they have airways disease, they have hyperinflation because of that. Okay. It looks like we lost the rest of it. Oh.
There's only you and I.
Oh dear.
Everyone's coming back.
What's happened? A few people are coming back now, maybe. Okay. All right, we'll keep going, perhaps. All right. Okay. So, as I said, VSDs are the most common form of acyanotic congenital heart disease. They cause about 30% of all types of congenital heart disease. They present usually at 2 to 6 months of age. It's very important to understand the typical age of presentation and the way they present. Sometimes they present just with an incidental murmur, like you hear a murmur in an otherwise well child, and sometimes they present with congestive heart failure. And whether they present just with an incidental murmur or the age at which they present, it depends on the size of the VSD. So very large VSDs will present at 2 or 3 months of age, and very small VSDs may present at 6 months of age or later, or not at all, because they just present with an incidental murmur. I won't go through the clinical features again, but we've talked about that. They present with tachycardia and tachypnea and congestive pulmonary congestion, both right and left side congestive heart failure. Usually they don't typically present with low output heart failure. They can do, but they don't usually present with congestive low output heart failure. It's usually congestive heart failure. And on auscultation, they have a parasternal heave and a displaced apex beat. Why? Because the left ventricle is enlarged. There's a pansystolic murmur, best heard at the lower left sternal edge, and it radiates below the xiphoid process, so underneath the ribs. If you hear a pansystolic murmur at the lower left sternal edge, you need to move your stethoscope across into the apex and also underneath the xiphoid process. If it goes under the xiphoid process and is just as loud or almost as loud, then it's probably a ventricular septal defect. Yeah. VSDs can be either small or large. They can be single or multiple, and they can be high or low in the ventricular septum. And whether the types of VSDs influence the presentation to some extent. Large VSDs obviously present very early, as I said, at 2 or 3 months of age, and small mid-muscular VSDs may not present at all. They might just be incidental findings that you find in a 7 or 8 year old child who's otherwise well, has got a murmur. When we're looking at a chest X-ray, again, this is the chest X-ray, like I showed you before, of a child who's got a ventricular septal defect. They've got cardiomegaly, and you need to have some idea of the cardiothoracic ratio. This is cardiomegaly with pulmonary congestion again, like the X-ray I showed you before. You can see the congested pulmonary veins all throughout the lung fields and the heart size being big. The cardiothoracic ratio in a child can be up to 0.6. All right, the cardiothoracic, so the maximum diameter of the heart compared with the maximum diameter of the thorax. All right, that's the cardiothoracic ratio, and it can be anything up to 0.6, but above 0.6, that's cardiomegaly. But it's usually the general pattern. When you look at this chest X-ray, you can say cardiomegaly with pulmonary congestion. I think it's probably a form of congenital heart disease, probably a VSD. Of course, it could be a few other things too. It could be myocarditis causing this degree of pulmonary congestion. But if you look at this X-ray and you look at this X-ray, they look similar in terms of the pulmonary congestion throughout the lung fields. Or it looks very different, for example, to looks very different from pneumonia, for example, doesn't it? You can see the congested pulmonary veins throughout the lungs. Right? I said that when we're trying to make a distinction between congenital heart disease and, for example, bronchiolitis, then it's useful to know what the clinical picture is, the age of the presentation of the child, the clinical signs, the chest X-ray, and the ECG. And if the ECG is normal, then probably it's not congenital heart disease. If the ECG is abnormal, then it might be congenital heart disease. And I thought I'd just try to run through some of the ECG abnormalities that go along with the ventricular septal defects, because it's useful to know, firstly, how to read ECGs and how to link them to certain forms of heart disease. All right. And so when we're thinking about the ECG, it's useful to know exactly what each part of it means. And we know there's a P wave followed by a PR interval, followed by a QRS complex, followed by a T wave, and then the P wave again. And it's just useful to know what each of those things actually mean. So the P wave is atrial depolarization. It's somewhere, usually the sinoatrial node, which is up on the elevated in the right atrium, that sets off the impulse that goes to the AV node. All right, and so that's a relatively short distance. That short distance is the PR interval. From here to here is the PR interval. All right, that's the SA node to the AV node. All right, the impulse starts at the SA node. The PR interval is the SA node to the AV node. The duration of time that the ECG takes to go all around the ventricles is the duration of the QRS complex. All right, so ventricular ventricular. Okay, thanks. Yeah, so the the duration of the QRS complex is ventricular depolarization. All right, and that's usually very quick, the ventricular depolarization, and it's only prolonged if there's some ventricular hypertrophy, and so the electrical impulse takes a longer time to get around, or if there's a bundle branch block, then it takes a lot longer for the ventricular impulse to get around the ventricle. Right, and then there's the T wave is ventricular repolarization. Right, and so if you understand each of the components of the ECG, you can understand why they'll be different with different sorts of pathology. So let's just look at the ventricular the abnormalities that occur with a large ventricular septal defect. So when you're reading an ECG, the first thing you should do is look at the heart rate, and then the heart rhythm, and then the PR interval, then the P wave morphology, then the QRS duration, the QRS axis, and then signs of ventricular hypertrophy. If you get used to reading ECGs like that, then it becomes quite easy. The heart rate, remember, is 300 divided by the number of large squares in the ECG. So let's do the heart rate in this case. There's 2 large squares between the RR interval in this ECG. So that's 300 divided by 2. So there's 150. The rate is 150. The rhythm is sinus if there's a P wave before every QRS complex, and if there's an upright P wave in lead 1 and AVF. Right? And so in this ECG, there looks like there's a P wave before every QRS complex. Right, and there's an upright P wave in lead 1. Lead 1 has an upright P wave, and AVF also has an upright P wave. So you can say that this is sinus rhythm with a heart rate of 150. The PR interval should be less than 4 small squares, so less than 0.16 in a child. It's a bit age dependent, but if you count the number of small squares, 1, 2, 3, almost 4, but there's about 3 small squares. So it's somewhere between 0.12 and 0.16 seconds. So the P wave, the PR interval in this case is normal. The P wave morphology should be the main thing you should remember. It shouldn't be more than 2 small squares across and not more than 2 small squares high. All right, so 2 millimeters by 2 millimeters is the P wave morphology. And in this ECG, it's quite small, isn't it? It's only about 1.5 millimeters. Any of the P waves are relatively small. They're not peaked and they're not too prolonged. Right? So there's no evidence. The P wave morphology influences whether or not you've got right or left atrial hypertrophy, and there's no evidence of right or left atrial hypertrophy in this ECG. Okay. And then finally, you need to look at, we should look at that. We'll look at the curious axis in a moment. The curious duration, it should be less than 2 small squares, and it is quite narrow, isn't it? It's very narrow, the curious duration. So here you've got a heart rate of 150. You've got a normal PR interval. So it's sine and there's a P wave before every curious complex. So it's sinus rhythm. And there's a normal PR interval, and the P wave morphology is normal, and the curious duration is normal. When we look at for signs of ventricular hypertrophy, then what we should be looking for is the size of the R waves and the S waves in the chest leads. All right, in leads V1 to V6, and as you need to have some just some rules, and so if you should look at the R wave in V5 and the S wave in V2 and add them together, and the R wave in V2 and the S wave in V5 and add them together. All right, and so. And the reason for that is V5 looks predominantly at the left ventricle and V1 looks predominantly at the right ventricle, right? And so if you've got a large R wave in V5 then it's most likely you've got right ventricular hypertrophy. If you've got a very large a large R wave in V1, you've got probably right ventricular hypertrophy. If you've got a very large R wave in V5, you've probably got left ventricular hypertrophy. So in this case, if you add up, what you should do is add up RV5, all right? So 5, 10, 15, 20, 25, probably 27. RV5 plus SV1 or SV2, 5, 10, 15, 20, maybe 22 there. So 27 plus 22, that's when you're looking for right ventricular hypertrophy. RV5 plus SV2, 27 plus 22 is 49. So that's more than 35. So there must be a degree of left ventricular hypertrophy, RV5 plus SV2. Similarly with RV2 plus SV5, 17 plus 20, in this example, there's more than 35. So you've got some degree of right ventricular hypertrophy. Basically, if you look at the ECG and you see very tall R waves and very deep S waves in the chest leads, then you've probably got ventricular hypertrophy. And that's what you see when you in a child with a VSD. You won't see that in bronchiolitis, but to make that distinction between bronchiolitis and a ventricular septal defect, then the ECG will probably be abnormal by the time the child presents in congestive heart failure. Right? And so when you're putting this together, you've got a child who's 4 months of age, presents with tachypnea and tachycardia, has signs of congestive heart failure, and has a large cardiothoracic ratio on chest X-ray, and crackles throughout both lung fields, and has an ECG that shows biventricular hypertrophy. it's most likely going to be a VSD. You can confirm that, of course, by doing an echo, but you can make, most of us can make the diagnosis just with those simple tests. When you're looking at the ECG, you should also look at the QRS axis. And I've spoken about this before, but if you, the QRS axis will be often abnormal when you've got congenital heart disease. And to look at the QRS axis, you should look at the net deflection in lead 1 and the net deflection in lead AVF. So just going back to here, the net deflection in lead 1 is negative, right? So it's probably 3 up and maybe 5 or 6 down. So the net deflection is negative in lead 1. And in AVF, the net deflection is positive. So there's it's probably 5, 10, 15, 16, 17, 18 up and 4 down. So probably about 15 net deflection. So when you're doing that, the net deflection is negative in lead 1 and the net deflection is positive in lead AVF. And so you just draw a vector diagram and you can see that the QRS axis is more than 90 degrees. And when you've got a congenital heart disease, often there'll be an abnormal QRS axis. I won't talk too much about that today, but I think I just want you to get used to reading ECGs regularly and trying to understand what they're likely to mean in terms of each of the components of the ECG, the P wave, the PR interval, the QRS duration, the evidence of ventricular hypertrophy, etc. When we are reading pediatric ECGs, we need to realize that there are some differences with age, and children have more often have a right axis deviation, and so their mean axis will often be more towards 90 to 180 degrees. It'll often be in this quadrant, whereas in adults, it's always in this quadrant, 0 to 90 degrees. Now, when children, the question is, why do children present at the age of 4 months with their ventricular septal defect? What is the reason why they typically don't present when they're first born or in the first couple of months of life? And usually that's because there is an equilibrium between the vascular resistance in the left and the right side of the heart. And so if the resistance is roughly equal, then less blood will flow from the left side to the right side. The reason they go into heart failure is because of increased pulmonary blood flow from the left side to the right side of the heart across the ventricular septal defect. And that occurs because of a drop in pulmonary vascular resistance, which allows blood to flow across the VSD. And that can, as children get older, from the time of birth to the first 6 months, then their hemoglobin drops, and that reduces their pulmonary vascular resistance, and that increases the blood flow from the left side to the right side of the heart. And so it's important to understand why children present in heart failure. And typically it's because their hemoglobin's dropping. That's a normal phenomenon for the hemoglobin to drop. But sometimes children get anemic as well. So, and they present because they've got increased pulmonary blood flow, and they have chest x-rays that look like this because they've got increased pulmonary blood flow, very congested lung fields because of the increased pulmonary blood flow, because of the left to the right shunting of blood. Okay. When a child's got a ventricular septal defect or some form of congenital heart disease, then often there's a neuroendocrine cycle that is set up, a neurohumoral cycle that causes the heart failure to get worse. And I just wanted to explain happens at an endocrine level that makes heart failure worse. And this is the basis for some of the treatment we have for heart failure. So children, they may have slightly low cardiac output or low blood pressure, and that causes the kidneys to release renin. So if they've got a VSD, their cardiac output may be low, they have more renin being produced by the kidneys. That gets converted into angiotensin by the angiotensinogen, an enzyme from the liver, and then angiotensin converting enzyme converts the angiotensin 1 into angiotensin 2. And angiotensin 2 is the strongest vasoconstrictor in the body, and that causes generalized vasoconstriction, and it reduces urine output, and therefore there's more retention of water. So if you've got reduced urine output and reduced GFR, glomerular filtration rate, then there'll be increased retention of water, and therefore the blood pressure will go up. But it also leads to heart failure. So you've got a bit of low output, high levels of renin, high levels of angiotensin and angiotensin 2, more vasoconstriction, retention of water, retention of salt, and that causes edema and congestive heart failure. And so, although this is the way the body tries to adapt to low blood pressure, it ends up in many cases that it leads to congestive heart failure because of the increased salt retention, increased water retention, higher blood pressure leading to these responses, all right, reduced urine output, etc. So the treatment of heart failure, a lot of it involves reversing these pathophysiological changes, all right, and so trying to reverse the excessive retention of water, the excessive retention of salt, the excessive vasoconstriction. They're all part of the treatment of heart failure. And so we give diuretics, for example, furosemide or spironolactone, to reduce salt and water retention. That will reduce the preload on the heart, so the congestion that in the venous circulation, and it reduces general pulmonary congestion. So diuretics. So most children with heart failure will have them on furosemide given at least twice a day, sometimes up to 4 times a day, and spironolactone usually twice a day. Then we use agents that block angiotensin converting enzymes. So it blocks this the production of ACE, and that leads to reduced levels of angiotensin 2. So there's reduced vasoconstriction and reduced effect on glomerular filtration rate. So it allows the kidneys to pass more urine. And so giving enalapril or captopril will cause vasodilatation, so reduced afterload on the heart, so that if you cause vasodilatation, the heart doesn't have to do too much work to pump blood around the body. Whereas if you've got intense vasoconstriction, then the heart has to do a lot more work, and it'll just go further and further into heart failure because the muscle will fail. We have to maintain nutrition in children who've got heart failure. They use up a lot of energy. You look at a baby who's got a ventricular septal defect, and they're using up a lot of energy in their tachypnea, and so we need to maintain nutrition, and often that's with it may be with some supplemental feeding or nasogastric feeding. If their hemoglobin drops too low, then they'll have increased blood flow through their lungs, and so we should try to maintain their hemoglobin somewhere between 10 and 12 grams per deciliter. And if they've got marked tachycardia, like a heart rate above 160 or 180, then using digoxin for rate control can be helpful. It's probably not proven, except if the child's in atrial fibrillation. That can definitely help. We should use digoxin. But if a child's got a heart rate of 180, then slowing their heart rate to about 140 or 150 can be useful. when you're using digoxin, you've got to watch you don't slow the heart too much. And if the heart rate's less than 100, then probably that will be detrimental to their heart function. So if you're going to use digoxin, just be very careful about what effect it has on the heart rate. Sometimes you see children on digoxin that have got heart rates that are below 100 in heart failure, and you know that their heart rate is not sufficient for their for their heart to function well. If usually in children with VSDs, we put them on medical management first, and if that fails, then they need to have surgery. Not all children with VSDs need an operation, but most of them do. Some will close spontaneously, but others, if you've got heart failure that's not controlled with medical management, or the child's failing to thrive, or they're developing pulmonary hypertension, or they've got a high, what we call QP-QS ratio, they've got more an excess of pulmonary blood flow, then they need to have an operation. Sometimes you can manage them for a period of months while waiting for surgery, but you should book all those children for surgery. I was going to briefly mention the other forms of left to right shunt and acyanotic heart disease. Ventricular septal defect is the most important one, and the other ones are usually just variations of that. And so I think it's good to be an expert in ventricular septal defects and know that things like ASDs and AVSDs and PDAs, they'll be similar, but they have differences. So for ASD, for example, they almost never present like a VSD. They rarely present with heart failure because they're relatively small. I mean, if it's a very large ASD, or the child's got a ASD and a VSD, then of course they present more like a VSD. But an ASD is a relatively small defect that doesn't have as big a hemodynamic effect. They often present as an incidental finding, an ASD, as a incidentally found murmur. They may have what we call fixed splitting of the second heart sound. You can, if you listen to enough heart sounds, you can often hear that. And ASDs can be what's called a primum ASD. That's very low in the intraatrial septum, so low down, or it can be a high up, like at the level of the fossa ovale, which is just a natural hole in between the atrium that doesn't close over. The ECG of an ASD is usually normal, although sometimes there can be a right bundle branch block. Why? Because there's more blood flowing from the left side to the right side, from the left atrium to the right atrium, all right? The left to the right atrium, and therefore there's more blood going through the right ventricle. And so that can lead to right ventricular hypertrophy. Unlike with a VSD, you can have biventricular hypertrophy. With an ASD, the blood's only going into the atrium, so from the lungs into the atrium, and then across to the right atrium, and then down to the right ventricle. So the left ventricle's left out of it. The left ventricle is not involved in an ASD, so you'll never see left-sided changes on the in an ASD. But you might see a right bundle branch spot because of an enlarged right ventricle. So therefore, it takes longer for the ECG rhythm to go through the right ventricle. Similar to an ASD, I suppose a patent ductus arteriosus is much less common than a ventricular septal defect, but there's two different types. One that occurs in premature babies, and the other one that's just a congenital PDA that you might find in older children. Sometimes they'll present a bit like a VSD. They'll present in heart failure, but that's usually a form of congenital patent ductus arteriosus. That's rare, but they may present with cardiomegaly and pulmonary congestion. But the characteristic feature of a PDA is that they'll have a wide pulse pressure, whereas with a VSD, usually the pulse pressure is relatively narrow, and the the pulse volume is relatively low, whereas with a PDA, there'll always be a bounding pulse. All right. And so they may have a very wide pressure. In a preterm baby, they might have a pulse pressure of 55 on 18, for example, a very wide pulse pressure, or in an older child, they might have a pulse pressure of 120 on 20, a very, very wide pulse pressure. They're very different to a VSD. Right? And the murmur will be different, a continuous murmur throughout systole into diastole. The murmur may be a bit hard to distinguish if you're not experienced, but it's putting it all together. A wide pulse pressure with a continuous murmur, more likely to be a patent ductus arteriosus. Sometimes PDAs will close spontaneously, but otherwise, other times we just have to use the same sorts of treatments for that we do for a VSD. So diuretics, sodium and water restriction, optimizing nutrition. For preterm babies, you can try indomethacin. That works well to close the duct in preterm babies. So either indomethacin or ibuprofen will work in most cases, more than half the cases that will work. It doesn't work so much in large congenital PDAs that present in the child who's 1 year of age, that they don't usually close with indomethacin or ibuprofen. You should try to correct the anemia, because again, that reduces the amount of what we call the transductal gradient. It reduces the amount of flow from the left side to the right side of the heart, all right, from the aorta to the pulmonary artery, because the pulmonary vascular resistance is elevated. And most of the congenital forms that you see in older children, if they're in heart failure, that will require surgical closure so that they don't go into pulmonary congestion or pulmonary hypertension. And then, so we've talked about ventricular septal defects. We've talked briefly about ASDs and how they differ. They're slightly different in that they don't present symptomatically. Typically, they may be more likely to be an incidental finding. We talked about PDAs, either in preterm babies or older children. And then there's the combination of all of those things. So an ASD and a VSD occurring together. And that's called a complete AV canal, or an AVSD. So an ASD, a VSD, sometimes the mitral valve or the tricuspid valve are abnormal as well. This is the commonest form of congenital heart disease in Down syndrome. And complete AV canal or an AVSD is an uncommon form of heart disease in non-Downs children. So rarely do you see it in otherwise normal children, but typically in children with Down syndrome. These children present early because they've got a very large VSD and they've got mitral regurgitation as well. So there's an abnormality of the mitral and the tricuspid valves. They present usually with severe heart failure and cyanosis because they've got mixing of blood at the ventricular level. There's no separation between the ventricles, left to right, both at the atrial and ventricular level, and they have severe and early pulmonary hypertension. Usually, they have a cardiomegaly like a VSD with severe pulmonary congestion, but they have cyanosis, so they do look a bit different. And they typically have a large left axis deviation and left and right bundle branch blocks as well. So just think of if you see a baby with Down syndrome who's cyanosed, who's got a large, what sounds like a large ASD, they've probably got an AV septal defect. Yeah. Look, we might stop there, I think, because we've covered today the causes of left to right shunt. That's what I wanted to try to cover today. The common cause of left to right shunt. We've talked about how we distinguish between heart failure that's congestive and heart failure that's low output. We've talked about how we make the diagnosis of a VSD based on the age of presentation, the clinical signs of the child when they present, the the chest X-ray changes of pulmonary congestion and cardiomegaly, and the ECG changes that show often biventricular hypertrophy. And we've talked about ASDs and how they predominantly spare the left ventricle, but the abnormalities that you see they're usually incidental, they're often incidental findings, or they, as an incidental murmur, or the child will present with some degree of pulmonary hypertension, but have a right bundle branch block on their ECG. We've talked about a PDA, how they typically have a wide pulse pressure, right, and bounding pulses compared with a VSD where there'll be low volume pulses, right? And we talked about an AVSD, which really only happens in babies with Down syndrome. So I wanted to just talk about heart failure in general and the first and most common cause of heart failure, which is left to right shunts. Maybe next time we'll talk about obstructed left ventricular outflow tract and cyanotic forms of heart disease. All right, so maybe it's worth just going back and revising your pediatric cardiology and thinking about all the different left to right shunts that we can have. All right. Okay, so I think unless there's any questions, I might stop there today, and we'll do some more in the coming weeks.